Assalamu alaikum everyone. Today our topic of discussion is aortic regurgitation. It is incomplete closing of aortic valve or incompetent aortic valve which causes the regurgitation of blood from aorta back into the left ventricle or reflux of blood from aorta back into the left ventricle. Now come to its causes. The most common cause is rheumatic heart disease, but the most common infectious cause is infective or bacterial endocarditis. The other very rare causes are long-standing primary hypertension, aortic dissection in which the blood is accumulated between the tunica intima and tunica media, which causes the incompetent aortic valve. The other rare causes are Takayasu arthritis, syphilic aortitis. In tertiary syphilis, there is inflammation of aorta. If it spreads to the valves, then it becomes incompetent. The other causes are Marfan syndrome, ankylosing spondylitis, and trauma. Let's talk about its pathogenesis. Due to the incompetent aortic valve, that is reflux of blood occurs from aorta back into the left ventricle even during the diastolic phase. Normally during the diastolic phase, that is during the filling phase, there is a closing of pulmonary as well as closing of aortic valve, but here in this case the valves are incompetent, so there is a reflux of blood from aorta back into the left ventricle. Due to reflux of blood, there is increased end diastolic volume during the diastolic phase, and due to increase end diastolic volume, remember the Frank Starling mechanism, the more volume, the more stretch on the valve of heart, the more it will contract. So due to increased end diastolic volume, it causes the more powerful contraction, so there is more ejection of the blood as a compensation. So the stroke volume is double in this case. Due to increased stroke volume, the systolic blood pressure rises. But during the diastolic phase, that during the relaxation phase, the pressure in the aorta decreases. So the decreased diastolic blood pressure but increased systolic blood pressure in this case. This due to increased end diastolic volume, that is volume overload, that is a compensatory mechanism. The hypertrophy of the left ventricle occurs, and this hypertrophied left ventricle eventually leads to dilation of the left ventricle and causes the left heart failure in severe cases, and regurgitation of blood occurs. Due to this regurgitation, there is a pulmonary congestion occurs. These are the features in advanced stages of aortic regurgitation, that the features of left ventricular failure or the left heart failure occurs in these patients. So this was little bit about the pathophysiology. Now come to its clinical features. Come to its symptoms. In mild to moderate aortic regurgitation, the patient may be asymptomatic or there may be a palpitations, because during the diastolic phase, as we have discussed, there is reduced diastolic blood pressure. So there is a decreased perfusion during the diastolic. Because of reduced diastolic blood pressure, there is a decreased perfusion to the viscerals. So due to decreased perfusion to the viscerals, there is compensatory increased sympathetic over discharge. Due to increased sympathetic over discharge, there is sinus tachycardia. So the patient may feel palpitations in mild to moderate cases of aortic regurgitation. But in severe aortic regurgitation, the patient may feel breathlessness or shortness of breath or dyspnea or difficulty in breathing. This shortness of breath is because of, as we have discussed, that features of left heart failure, that dyspnea occurs because of this pulmonary congestion in very severe cases of aortic regurgitation or very advanced aortic regurgitation. The next clinical feature is angina. This angina is because of ischemia. The ischemia may be due to two reasons. One is this left ventricular hypertrophy increases the oxygen demand of myocardium, and the second reason is that decreased diastolic pressure. Due to decreased diastolic pressure during the diastolic phase, there is reduced diastolic blood pressure, so there is decreased perfusion during the diastolic phase of the heart. So during diastolic, reduced perfusion and also increased oxygen demand causes the ischemia and leads to angina in these patients in severe aortic regurgitation. Now come to its clinical signs. That the patient has important pulse which is known as Corrigan's pulse, water hammer pulse, or also called collapsing pulse, because as we know that there is a double stroke volume which leads to increased systolic blood pressure. So there is markedly increase in systolic blood pressure which causes the rapidly increasing the pulse, that collapses suddenly as the arterial pressure decreases rapidly in late systole as well as in the early diastole. So there is increased systolic pressure, and then suddenly decreased diastolic pressure causes this collapsing pulse or water hammer's pulse. And doctor checks this collapsing pulse by elevating the hand of the patient and then feel the pulse on the wrist or either femoral pulse. The next important clinical sign is widened pulse pressure. As we know that the pulse pressure is difference between the systolic pressure and diastolic pressure. In this case, due to double stroke volume, there is increased systolic blood pressure, and due to collapsing pulse, that during the diastolic phase there is reduced diastolic blood pressure because of backward flow of blood back into the heart. So there is reduced pressure in the aorta during the diastolic phase. So this leads to increased or widened pulse pressure. Suppose if the patient has the systolic blood pressure of 200 and diastolic blood pressure of 50, so the pulse pressure is 150, that is widened or increased pulse pressure. The next important sign is Quincke's sign. This Quincke sign is visible pulsations can be seen in the nail beds of the patient. All these signs are because of hyperdynamic circulation and double stroke volume. So the first sign is Quincke sign. In Quincke sign, there is visible pulsations in the nail bed of the patient. The next important sign is Demosid sign. In Demosid sign, there is rhythmical jerking movement of the head because of hyperdynamic circulation and double stroke volume. The next sign is Corrigan sign or dancing carotids. Because of the same reason, carotids are dancing, that is suddenly increased pulse and then suddenly collapsing pulse. So the Corrigan sign is dancing carotids, as you can see in the animation. The next sign is Muller's sign. In the Muller sign, there is systolic pulsations of the uvula occurs in the Muller sign because of the same reason, that increased systolic pressure and increased stroke volume of the blood. The next is Derosius sign. This Derosius sign is because of pistol short sound heard over the femoral arteries, and the reason is same as that we have discussed in the previous signs. Now come to the next few words about the murmurs in the aortic regurgitation. The murmur is early diastolic decrescendo murmur. As we know that during the diastolic phase there is a closure of pulmonary and the aortic valve. Suppose the S1 is produced because of the during the systolic phase because of the closure of mitral and the tricuspid valve, and then systolic phase of the heart occurs, and then during the diastolic phase S2 is produced, which shows the closing of pulmonary valve and the aortic valve, and then diastolic phase occurs. During this diastolic phase there is decrescendo murmur, that is decreased in progressive decreased intensity of the murmur. This is early diastolic decrescendo murmur. The murmur's intensity increases with increased resistance, especially when the patient has the hand grip. Due to hand grip increased systemic resistance, which increases the intensity of the murmur. The next important murmur is Austin Flint murmur. This is because of the mitral leaflet movement. During the diastolic phase, there is a regurgitation of blood from aorta back into the left ventricle. So this due to reflux of blood, it basically fluttering of mitral valve occurs, that blood touches the mitral valve. So this there is a fluttering movement of the mitral valve or closing of the mitral valve during the diastolic phase. Normally it is open during the diastolic phase. This murmur can also be appreciated during the mitral stenosis. So this is Austin Flint murmur. There is displaced PMI, that is point of maximal impulse or apex beat is displaced from its normal side because of increased end diastolic volume or volume overload and pressure overload. And the next feature is fourth heart sound, that is S4 is produced because the atria contracts against the stiffened ventricle because of left ventricular hypertrophy, and crepitations at the bases of lungs because of the pulmonary congestion. Now come to its investigation. ECG is non-specific, which may shows the left ventricular hypertrophy, and because of ischemia, T wave inversion can be seen in the ECG. In the chest X-ray, there may be a left heart failure features like pulmonary congestion or etc. And there may be a cardiac or aortic dilatation because of high systolic blood pressure. Echo shows the dilated left ventricle and fluttering of anterior mitral leaflet because of the regurgitation of blood. Due to the same reason, we have discussed the murmur, which is Austin Flint murmur. And Doppler echo is a gold standard investigation, or the investigation of choice for aortic regurgitation. Doppler is important for the detection of reflux of the blood from aorta back into the left ventricle. The other investigations include cardiac catheterization. When echo is undiagnostic, the other investigations are cardiac catheterization, which shows dilated left ventricle, aortic regurgitation, and the features of dilated aortic root. So these are the investigations of aortic regurgitation. Now come to its management. In asymptomatic patients, the management is usually conservative, or maybe no management is required. And the conservative management includes ACE inhibitors or ARBs. ARBs includes candesartan, valsartan, and ACE inhibitors are captopril, enalapril. These two drugs reduces basically the afterload. Due to decreased afterload, the murmur intensity reduces, and it relieves the features of aortic regurgitation. And the other includes the annual echocardiogram should be done in these patients. And also there may be a salt restriction or decreased salt intake in these patients. So these are the few conservative management steps. Now come to the definitive management. The definitive management is AVR, that is alveolar valve replacement. This is the gold standard management in case of AVR, that is aortic valve replacement. In symptomatic, it is done in symptomatic patients if the patient has symptom of aortic regurgitation, if in asymptomatic patients in which there are no symptoms. But if the patient is asymptomatic, in cases if the ejection fraction is below 55 and the diameter of left ventricle is more than 55 millimeter. So these two are the indications for AVR, that is aortic valve replacement. So this was whole about the aortic regurgitation. Thank you so much for watching this video.